Test 1, 2, 3. Test 1, 2, 3. 3, 2, 1.
of things until Roger shows up so that we have a quorum to vote, okay? But we'll go ahead and get started. The first thing, we'll start with citizens wishing to address the committee. Are there any citizens here today? Okay. All right, so we will continue on then. We're going to go ahead and just table the approval of minutes until we can have enough to vote on it. And we'll go ahead and start with the quality reports. And Dr. Carla Putty is going to start us out with a patient story.
Thank you, Dr. Holland. Good afternoon, everybody. We have an exciting quality presentation for you today. I want to start by sharing a patient's story. And Derek, if you can hear me, we actually have a video for you. I show you a story that's really heartwarming and heart-touching, so I wanted you all to see it. So Derek, is this your cue?
Keep looking down. You unlock it for me. Put throw your towel back in. I'm Jake Tanner. I'm 17. I like throwing discus. I like playing guitar. I like to read books. I like weightlifting a lot. I had a toothache in the summer, and I was just kind of like, you know what, I don't really want to tell anybody about it because it's not a big deal. I'm just going to get over it soon, you know.
He was going for a school picture or something like that, and they told him to smile, and he couldn't touch his front teeth together.
So we went ahead and got our wisdom teeth taken out. Like a week later or whatever, I started having these terrible headaches, like I couldn't sleep.
Because a tumor was pushing his molars out of his jaw, pushing them up where he couldn't even close his front teeth.
So he had a osteoblastoma, uncommon tumor in the jaw, and the treatment for this tumor, because it's fairly aggressive and eating away at the jaw, the treatment is to remove it. And there's multiple reconstructive options. Most of them involve using bone from other parts of the body. And in his case, we used his fibula from the leg. And one advantage of the fibula is that it can many times allow us to place dental implants and rebuild the teeth at the same time.
We had to go see Dr. Williams, and he had to tell us the whole deal with the surgery, and it was a big, really scary thing for us all. All of a sudden, he's like, yeah, we have to use that bone from your leg, and you might not be able to do sports again. They cut through here. They took out this portion right here. So they put it up here, because I didn't seem to like catch the gravity of the situation, because it was like, you know, every teenager thinks they're kind of immortal, so they're just like, you know, nothing bad could happen to me. And I know everybody says that, like you could die at any point, but like you don't really realize it until it happens.
Usually well over a year before things are complete. It's not very common. There's really only a few places in the country that are doing this with any type of regular volume, but they're strangely common here because of what we do. A lot of these get referred to us, but this allows him to really just with one procedure just wake up and be done and be made whole again.
There's a constant roller coaster. You have a good day, then you have 2 bad days, but you just keep on going forward.
I was like pressuring the doctors, like, when can I lift again? When can I lift again? And we started off low weights and stuff like that, building up into when I can actually get back to normal. Kind of what I learned from it was like, you can be like reduced so much, but then you can get back up. From that, perseverance was really the key to it all. Like always believing that I could get back into it, and that I could be as close to normal as I thought I would be able to.
Stories such as these remind us why we are in healthcare. And I thought I wanted to share this. I want to thank Jake for actually sharing his story, and his father in our communications department for doing such a wonderful job. And these are stories that happen every day at JPS, and Dr. Williams for he does a lot of these cases, so we do have the expertise and the volume to support care of osteoblastoma. So just wanted to share the story with the board. Thank you. With your permission, I would like to move to my next agenda, which is the Patient Safety Recognition Awards. These are awards we give out every month to teams that do an exemplary job in improving the care and safety of our patients. So with that, for the month of August, I'm looking for the winners for the month of August. It's my great pleasure to announce medical team True Worth as the winners for the August 2023 Charles E. Weber Jr. Gold Commit Award. In 2022, the medical home True Clinic hosted their first Women's Wellness Day, which is dedicated to taking care of health needs in women experiencing homelessness. That inaugural year, they closed 93 care gaps. They thought this was a low target. So in 2023, their aim is to actually close 200 care gaps during their second Women Wellness Day. They submitted 2 abstracts to the Healthier Texas Summit. It's a collaboration between It's Time Texas and University of Texas Health System in Austin, and both their abstracts were accepted. They provide recuperative services, which is a short-term specialized program that provides adults experiencing homelessness in a safe place to recover from acute injury or illness, and by providing patients with 27 access to providers and nurses. It is for these efforts that the team, the True Worth Medical Home team, are the recipients for the August 2023 Charles E. Weber Junior Golden Mid Award. So if you would like to take a photo with them.
Anybody that would like to be in the picture? Come on up.
For the month of September, it is my great pleasure to announce our Sterile Processing Department as the winners of the September 2023 Charles E. Weber Junior Golden Mid Award. The team has done really great improvements in making sure our instruments are clean. Our scope cleaning and disinfection processes are above 90th percentile. The team is always ready for surveyors and they have a great amount of knowledge about their instruments and their environment. The team has been recognized for their collaborative, transparent, proactive approach to improving processes. In addition to all of this, they're also engaged in multiple cross-departmental committees and work groups to constantly improve our sterile processing processes. For these efforts, the Sterile Processing Department are the winners of the September 2023 Charles E. Weber Golden Mid Award. The last one. With great pleasure, I announce Grapevine Colleyville School-Based Clinic as the recipient of the October 2023 Charles E. Weber Golden Mid Award. I will not go into details, but in May 2023, May being the busiest time of the school year, there was an unexpected, unplanned interruption of services at the school. The staff did not miss a beat. They immediately took collaborative action. They relocated to the Northeast Medical Home, and they were able to support patient care services without any break in services. For these efforts and to make sure that our students got the right care at the right time, despite the unexpected challenges that they faced, this team from the Grapevine Colleyville School-Based Clinic has been awarded the October 2023 Charles E. Weber Junior Golden Mid Award. I don't know if it's protocol, Madam Chair, but for the next one, I would like to stand and present from there.
Well, I just want to congratulate all of our winners. These are just amazing stories. Thank you, Dr. Carla Putty. But, you know, what I just love hearing is just above and beyond that our team members take it into their own hands when they come across difficulty challenges and push themselves to be better every day. And it's just reassuring to know that these are our caregivers and our team members. So thank y'all, everyone.
Thank you, Dr. Holland.
Do you want to go ahead and move into your fiscal year 23 year in review?
Thank you, Dr. Holland. Yeah, I would like to move. This is our starting of our FY 2024. I want to take this opportunity to recap the year and to highlight some priorities for next year. We started our leapfrog journey in 2015. We got a grade of D at that point in time, and over the many years, we've had one A that happened in 2021. And I am very happy to say that for the past few times, we have been a consistent solid B. We got our fall score of B, and we missed A by 0.183 points. So we were a really, really solid B, but not an A. And the aim is to actually get to an A, so we'll be working on that. In addition, we were also recognized by the American Nurses Credentialing Center as an organization that is committed to empowering and engaging a workforce environment. And for this, we were redesignated in our pathways designation by the American Nurses Credentialing Center. Next, we were also recognized by the American College of Cardiology for excellent care for patients who present with chest pain with acute coronary syndromes for 2023. We were recognized again by the AHA for excellent care in heart failure. We are an exceptional care for providing comprehensive stroke care within Fort Worth. We are certified by DNB for being really, really good and taking care of patients with stroke. And again, the AHA in 2023 gave us a Gold Plus for stroke care, just as DNB did. Own the Bone is a designation given by our colleagues at American Orthopedic Association. It's a recognition for us being a star performer in doing two things: in preventing fragility fractures and then taking care of patients post-fracture from a fragility fracture. So we were recognized for being a star performer by the American Orthopedic Association for this. We received a pharmacy award, the Warren E. Weaver and Richard E. Penna Award for 2023 from the Board of Pharmacy Specialists in Exceptional Pharmacy Care. As a note, all our clinical pharmacists at JPS are board certified in pharmacy. And then American College of Radiology gave re-accredited us for CT, MRI, ultrasound. There's another modality that I'm missing out, but 4 modalities were accredited by ACR. These are just some of the few recognitions we have received. I have selected these for their importance, their other achievements. I do want to tell that I'm not excluding anybody on purpose, but if I've missed anything, it's not on purpose, just an oversight. FY 2023, from a quality perspective, we had a share of successes. We did have our share of challenges, and I like starting with challenges because those are the things that we have to get better on for the future. This is a new slide the board has not seen. I want to orient you to this slide. On the x-axis is time, on the bars are the number of patients who have experienced the CODI, and the orange arrow that is going through is essentially showing our trend over time. Catheter-associated UTIs have been a challenge in 2022 and 2023, and they continue to be a challenge nationwide. We were just above our standard infection ratio. We should have been 1. We are at 1.01. Even though we are 0.1 more, we are taking a solid red on this because we want to make sure we get really good at this. The next slide is just to tell you, not for you to read the entire slide, but to tell you that it's a dedicated zero COTI, zero CLABSI team that is headed by Dr. Z from the ICU that has been doing a lot of work. We have completed a lot of action items that are in green. The next action item that actually I am looking forward to is actually a process wherein if our clinicians are ordering a urine culture in a patient with a Foley, it automatically triggers an evaluation by an infectious disease doctor to make sure that the indications for culturing urine are appropriate. Over the last decade, we have realized that the cost for fever in a hospitalized patient, with a Foley catheter is very unlikely to be a bladder infection. It's usually other causes. But we have been trained for decades to order urine cultures, blood cultures, chest x-rays, anybody in fever. So we're trying to optimize that process. That is going to be hardwired, built 3 days from now in Epic. And once that is done, I'm really hoping that the CAR-Ts that we have taken a hit for because of the ordering practices, that will decrease, and next year should be much better. We've had a lot of work that's happening on that. The next slide is colon surgical site infection. This has again been a challenge. We should have been at 1, but we are at 2.18. Colons, a couple of things about colon surgical infections. Unlike other hospitals, we do a lot of elective colon surgeries, but we also do a lot of traumatic colon surgeries, which are patients who have come with significant injuries or urgent needs for doing colon cases, and those also count in this. So we're thinking that our opportunities in colon site infection come down to 4 things. Are our surgeons documenting well? How is our glucose management? How is our perioperative antibiotic prophylaxis? And then how are we doing pre-operative skin care for patients who are coming for elective procedures? We've done a lot of work in educating our surgeons in making sure we get the right terminology. I just want the board to know that what the surgeon trains to write is not the same term the coding agency is. So you get dinged for things that you're thinking you're writing the right thing, you actually get negative credit for it. So we've done a lot of work in that. We've got more work to do in the space of glucose management, and I know there's a committee working on that, and then a lot of work is happening on the elective. We actually have our ERAS protocol for the colon surgeries that have gone live so that we can standardize skin care for patients. And anesthesia is looking case by case at every patient who did not get the antibiotic within 60 minutes of the incision, and they're looking at each case to make sure that is optimized. So I always say hope is not a good strategy, but there's a lot of work that's happening on each individual line item for colon surgical sites to get better for next year. Severe maternal morbidity continues to be a challenge. This has been a challenge statewide, and it's been a challenge countrywide. Our target was 1.88. We reached 2.42. In the world of severe maternal morbidity, I would say that we are actually we are close to the target than other institutions. There is a lot of work that's happening in 3 specific areas in severe maternal morbidity that's happening in our OB department. One is how do we detect and treat blood pressure? How are we anticipating and treating postpartum hemorrhage? And how are we actually do we have the processes to prevent peripartum infections, specifically choreo? The nuance that I want the board to be to know is that there is a sizable patient population that comes to JPS where we are seeing the patient for the first time. A lot of maternal morbidity and morbidity and mortality stems in the antenatal, prenatal period. So when women get regular health checks and their outcomes are better. We do have a lot of patient population that really do not get any prepartum or antenatal care, and we see them for the first time. So we do have patients who have significant social barriers to accessing care, and we're trying to understand how to make that better. So that is severe maternal morbidity. I think we are done with challenges, so I think we can start celebrating a little bit. So hip infections. So this is another new graph, so let me orient you to a little bit. So the orange wiggly line is essentially the number of cases we have done over the years. The gray arrow that's going up is showing the trend, essentially saying that we are doing more in hip surgeries month over month at JPS over time. And the green arrow is actually the trend of the infections. As you've seen, we've had very few infections on knees at JPS while we have done more surgeries. The surgical site infection for post C-section is also good. It's slightly lower than our SIR, but I wanted this slide to not so that you read every slide, but it's to tell you the amount of work that's happening across the world of surgical site infections, because the 4 items that you saw on the colons are exactly the same ones here. How are we prepping the patient? How are we taking, how are we documenting better? How are we taking care of antibiotics? And how are we managing glucose? So there's a lot of work that's happening in the world of surgical site infections. And the success that we saw in the C-section, I am hopeful that'll happen for our colons too next year. Cabbage, post-cabbage infections, this is really a success story. We didn't start 2022 well. We did have a serious increase in our post-cabbage infections. We did see a decrease in cabbage infections, but that's normal variation you get based on cases that happen in a hospital. But we've gone about 8 months without a single surgical site infection. And that's largely the work that has happened with the surgeons, the OR techs, and the SPD, and our infection prevention teams, the team that we recognized for September Golden Mid Award, is they came up with a process to clean their scopes in a different way, which was causing most of their infections. And you see the process improvement work and the investment the organization did actually resulted in absolutely zero post-cabbage infections for the last 8 months there. CLABSI was a huge success. I don't think I've seen this ever in the last 10 years of my life in healthcare leadership. There was a 50% reduction in CLABSIs over the past 12 months. And this, again, goes back to the team that I was talking about, the zero COTI and zero CLABSI team that looks at every single CLABSI and COTI. And we have a very good process on how our checklist for placing lines, our process for removing lines, and then for taking care of our lines. Specific shout out to our nephrology colleagues who have done a really, really good job in making sure our dialysis catheters are really well maintained. We do have a higher proportion of patients who have dialysis catheters than what I usually see because we have an access with, they don't have fistulas. The next one, this is a success and challenge. This is readmissions is always close to my left ventricle. I say this again and again. Readmissions was a success and a challenge because, when we look at all-cause, all-payer readmissions, we were at 11.1%. Readmissions was on our AIP goal. This is the only AIP goal that we did not meet, so that's why it's a challenge. When we look at Medicare readmission rates, just JPS Medicare readmission rates, we are at 13.3%, and the national average for the CMS population is 14.6%. So we were performing better than the national average for CMS patients. And I want to add a little bit nuance here. We do not see a high number of Medicare patients. So to get a metric to be better than national average when you have small numbers really, really reflects how good a care, because every time we have small numbers, I call it tyranny of small numbers because there's very little give wins, but we actually do really well with this population. We actually rank 50th percentile in JPS from CMS benchmark. I've never said this again before, but we had $0 penalties by CMS last year for readmission. And so it's a significant improvement, accomplishment to get our readmissions to where they are right now. Any questions on last year's work?
I do have a question on, if you go back to your slide on the one on prenatal care, you said we have a large number of patients coming that haven't received prenatal care here, right?
No, I said we do have a sizable number of patients who we see for the first time. They have not received they could have received antenatal care elsewhere, they could have received prenatal care somewhere, but we are seeing them for the delivery their first time. Okay. And one of the things I hear is we are also trying to understand the quality of that care that they received and how often that was, and trying to understand how can we streamline it, make it easier for patients to follow up with us so we can plan their prenatal course in collaboration with them.
Okay, you answered my question. I was wondering what was our plan, because I know they identified some time ago the areas where they were not getting care. So they set up a special program, Mom and Baby Club or something, and so that they could increase that. And so glad to hear that y'all looking at that.
Dr. Alawi, do we not have the doula program that United Way is doing for the 76104? Are you familiar with that?
The doula.
The doula.
So we are, for our maternal care, we We are currently working with the United Way and with our women's department to actually engage in that program.
That go out in the community,
Yes.
identify those moms who may not have prenatal care established for them and get them in here and then follow them
Absolutely.
through even postnatally. So,
And through the whole process.
yeah.
Absolutely.
Dr. Levy. Right, there are no additional questions, and I would like to move to my next section, which is articulating our quality priorities for 2024. The quality department, all of us follow an extraordinary number of metrics. There's actually a metric called PSI 90, which is a composite of 90 plus metrics, which we will be following all of those metrics to make sure that we're doing well on all of those metrics. But sometimes it's better to highlight a few priorities to make sure that we are laser focused on those. The reason we selected these, we've identified two categories. One is clinical, which we're used to seeing. The other are operational, and I'll get to the operational in a second. But one of the reasons for picking these metrics are because this is work that we've been doing. There are some metrics we have done well, like CLABSI, but CLABSIs are still monitored quite extensively from an external reporting and a payment standpoint. COTIs, colon infections, total knee infections, and severe metal morbidity, these are things that we have to continue to work on, and they're high priority both for a clinical, a societal, and a financial person. So these are the 5 clinical metrics that I would like to bring to you every board meeting to show you the improvements that we are doing. This one is a little bit different, which is actually operational metrics. Quality is providing the right care to the right patient at the right time at the right venue. Everything has to be right in order to deliver quality. When we don't have operational efficiencies, it becomes impossible to deliver high quality care. High quality inpatient care for an inpatient in an ED is not quality care. High quality inpatient care for someone who does not need to be in the hospital is not a good quality of care. So these are 3 process operational metrics that we would like to present every month. The first one is, I think, the most important, left without being seen in the ED. Some may know this data, some may not, but the proportion of patients who end up having serious medical illness that are not seen in the ED is about the same as the people who are seen in the ED. So it's a misconception to think that the patients were not sick because they left. Actually, they have the same amount of inpatient admission. We've done a phenomenal work about this. We want to keep continuing this work. Length of stay, again, is a very important metric. It's a very important financial metric, but the reason it's more important is anytime a patient is in a bed, in my mind, it results in it's not the right care at the right time. Hospitals do have, we are not very good skilled nursing facilities. We are not very good rehab facilities. We are good hospitals. So finding the patient in the right place at the right venue is important because we want to make sure the patients are getting better. And sometimes keeping them in the hospital is not the right answer. And again, 30-day all-cause readmission, it's actually, in my mind, it's a defect along the entire spectrum of process in healthcare, and this is a metric that we want to keep tracking because it's all-cause, all disease. It's not a true disease-specific. It's all-cause, all-payer. So these are the quality operational priorities that I wanted to share with you for 2024. Any questions, any feedback, any other metrics you want us to consider?
What's your goal with the left without being seen?
Yeah.
Because, oftentimes those are patients that they don't need to be in the ER anyways.
Yeah.
So you don't want to wait.
And Jill, correct me if I'm wrong here. We set I think we use our CMS targets to look at how busy our ER is and how many patients we see. I think the target for 2024 is going to be 3%. We started last year at 7%. But we've, since the last 4 months, done really, really well. As of 2 days ago for November, we were 1.8%. For October, we were 2.2%. So so we are under that 3% for the last 3-4 months. We have done a lot of work. Huge thanks to our nursing colleagues and our IAS colleagues who actually have a physician all the time in the front door. So we are triaging the patients and bringing them here. So the target would be to be under 3%.
The length of stay reduction is a challenging target just because, well, it's super important. I think a lot of the reasons that patients stay in the hospital is not because of medical reasons, but because of social reasons. And so I think that's going to take a huge team of social workers and community workers to kind of help with that. The thing that, we worry about is just, patients are not being discharged in the hospital just because it's time for them to be discharged, that they're medically appropriate for discharge, but then they have the resources so that they don't be readmitted.
Yeah, I think, to your point, Dr. Holland, discharge planning starts the second the physician writes an admit order. I think our systems have to get better to that thinking of saying, okay, if I'm admitting a patient, how many days do I expect them to be here? Anticipating the discharge challenges, anticipating what social needs they might have, what transportation needs we have. And to your point, we have an entire team. I'm not the one working on length of stay. I have an entire team of case managers, physicians, who are really working very hard. What we are trying to understand is what are the other challenges that are not just the pure acute, but what are the outside the hospital challenges? What are the financial challenges? What are the housing challenges? And how we can anticipate them on day one. Because we're very good at anticipating them on day 20, when we've taken care of the patient, everything has gotten better, now we can do it. But how do we do it on day one? How do we prep for it? And how can we shave half a day off? How can we take a few hours off? Because it is a metric. Every bed is precious in a hospital, and we want to make sure that we have capacity. It's hard work. It's not easy work. Thank you. That was a good discussion. Any more questions? No? Okay. I'm happy. All right. So healthcare, appropriately, is one of the most regulated industries in the country, maybe like fire, gasoline, petroleum, deep sea, oil drilling, and healthcare. We are regulated quite extensively. The last I asked Angela Ware, who's sitting behind me, check how many agencies regulate us. She said something to the effect of 35 to 40 agencies have some sort of oversight over healthcare. And I've also been told that there is a visual of those agencies, and next time I can bring that to you, show you how intricate a spider web of agencies oversee regulate. And it's a good reason to do it. It's a very important industry to make sure our patients are getting the care that they need. This year was also a very, very busy year, but I wanted to share a few highlights of the surveys that happened at JPS and our results on those surveys. Now I'm going to try to read through some of them. I talked to you about Pathways of Excellence before. ACGME had, these are the two big surveys that they had last year. They had a clinical learning environment review where they came and spent some time with us trying to understand the clinical learning environment and how students perceive that environment to be. It was an important visit for us to understand and see how we can make that experience better for them. And also they did their institutional site visit, which is one that they do every 10 years. So it's a big, comprehensive, detailed review. We got very good feedback. But the review was, the survey is so extensive that we still haven't received our results. So we will be getting our results, and once we know, we'll be sharing. But the on-site feedback was very good. In January and February, we had a successful survey for the Ryan White A Part A grant. This is a grant that provides a sizable amount of funding for our HIV patients, HIV services at JPS. It's designed to ensure that we are following the many fiscal, policy, and service provision requirements, and we met all of them. I spoke to you about the American College of Radiology and the stroke, so I'll move on to our Level 3 survey. For background, there are 4 levels. There are 4 levels in neonatal. To be Level 4, you need to be able to provide neonatal surgery. So that's only provided in Cooks in Fort Worth. But we are being redesignated as a Level 3 survey. I was part of that survey. It was very impressive to see how ready our team was. I've never seen binders that big, and the amount of papers that we had to show the proof of documentation, it was just impressive to see the team. This was my first survey, sitting with the surveyors and seeing the team response. I was like, wow, this is amazing. And then in September 2023, we had a successful survey by the Texas Commission on Law Enforcement. I had to learn this, but the Texas Commission on Law Enforcement is a state agency that ensures that the people of Texas are served by highly trained and ethical law enforcement personnel. So we had that successful survey. And last but not the least, I'm also forgetting other surveys, but the College of American Pathologists did our big lab survey, and we had one finding, and that was, I think, to get periodic feedback from our physicians as to how we were doing, and we got that taken care of. It was a really good survey that we had. So again, just to share with you, we experience an extraordinary amount of survey activity. This happens every year. But we can't get to this success without our teams being all ready and being ready all the time. So this is just to tell you that we are right now in preparing for our accreditation survey by Joint Commission. We are accredited by the Joint Commission. So we last had our survey in November 2021. We finished our submissions for the corrective actions for that. We completed this mock survey after that to make sure that we are good. And we are right now at this point in time where we are getting ready for our next one. Our window opens in April 2024. And what that means is we have to be really, really good. And what we're doing is we're really getting our teams engaged. And the next slide, I'll show you what we are doing. More importantly, we are going to have a mock survey again in order to prep for that. And that window is open. It might be, despite the holidays, that window is open. And we want to make sure that we get a very good real assessment of our mock survey when it happens, so that we really understand what our strengths and weaknesses are. In the interim, we have continued our ongoing tracers and audits. We are rounding weekly our quality and our risk and accreditation teams and infection prevention teams, environment of care teams rounds weekly. They round together. They are doing comprehensive audits. We are maintaining situational awareness of what's happening in the regulatory world. We are maintaining situational awareness of where are the areas that are being the most problematic areas in healthcare and how are we performing. And we are working with our frontline teams and preparing them to be familiar with the work they do, not just the work they do, but the policies that support the work they do and where they can find that, and then auditing to that work. There's a lot of survey activity going on right now in order to prep for that. So I wanted to give you that feedback. I think that brings me to the end of my presentation here, but I wanted to get any feedback, any thoughts, any comments.
I think you're getting ready for Joint Commission and how you're doing the mock surveys are great, because when they come in, it's the time that staff don't need to be standing there not knowing if they're going to be asked some questions. So good work. Good job. Okay.
Thank you, ma'am. We asked that question of the staff during our last town hall. What will you do to become regulatory ready? And we had people coming up with very creative ideas of doing scavenger survey hunts. I haven't figured out the definition of that, but we might figure out that one too. With your permission, Dr. Holland, if I can, before I go to the next one, I would like to take a moment to acknowledge a few people who actually made this presentation possible. I've recognized that for the last 2 weeks, 2 times I've not told you that people do this work. A lot of work goes into making these slides in addition to all the work that supports this. There are 3 people sitting behind me, Dr. Saba Assad, Jen Fondon, and Angela Norris. They have spent countless hours trying to work and making those presentations well. So I just want to make sure I acknowledge that of all the hard work they have done in making this possible. Thank you.
Yeah. Next, we'll have Daphne speak to us about workplace violence.
Thank you, Dr. Holland. And this is really to piggyback on Dr. Kalaputi's comments about regulatory preparation. And in follow-up to the June 26th presentation that you all received on workplace violence, we just want to keep it top of mind for this committee. This is where the results of that work will be continuously reported out. As you'll recall, similar again to what Dr. Kalaputi shared, we have teams that mobilize around this work without even being prompted, as discussions were going on around the Senate bill that was going to come out that would put some more specific hospital licensure requirements on hospitals. We had leaders from behavioral health, nursing, facilities, and HR that came together and really formed a committee to start doing this work. And so they got us really ahead of the game on what we have to do. But we did make an intentional decision to kind of coordinate the work under our enterprise risk team. And we're in the process of hiring an individual that can be involved in what those committees are already doing. And we do hope that you continue to hear about that work across the organization, because we don't see that as siloed, but it's really about what the organization is doing to prepare in the event that we have those situations. So as I mentioned, there are, in addition to the Joint Commission requirements, there are hospital licensure regs that come online not later than September 1st, 2024, that really require that organizations have a prevention plan, do education or tracking data around that. We've already done a high-level computer-based learning that we've kicked off to make sure that all the staff had that higher level training, and we will follow that with more focus, de-escalation training for certain staff members. We are in the process of doing our self-assessment. As you recall, last year we had a third party come in and do an assessment of the organization and identified some opportunities for us, and we'll continue to have periodic self-assessments to make sure that we are ready. And what I was really impressed with as we started to coordinate this work was the steps that we've already taken to make sure that we can do data analysis around the types of events that we have. Right now, we're really just encouraging the reporting so that we can capture all of the information, and it's anything from someone just feeling a little bit threatened to, having a full-on violent event. We allow the reporters to choose broad categories that they can identify, and then the team that is receiving that information is really reviewing those events to kind of categorize them in the more appropriate buckets. And then really our next phase will be that we'll really start to refine that data, identify trends, and develop meaningful reports for this committee. And that is update on workplace violence. I hope not.
All right, so,
We can go into close.
Okay.
We have a member that's on, so hopefully he'll be here.
so we're going to table the quality assessment performance improvement plan until after close, just because we are still waiting on one of our board members to show. So we'll move to close. First, I need to approve the minutes from the Quality and Patient Safety Committee meeting from August 14th. Can I have a motion to approve the minutes? So it has been approved, the minutes. And then Dr. Carla Pudi is going to present the QAPI to us.
Yeah, so the Quality Assurance and Performance, the Process Improvement Plan is a plan that we're required to do every year. The last plan was approved in December 2022, I think. Yeah, 2022. I was not here. I started working on the plan sometime in June, July, and I have to apologize to you. The version you're seeing is version 44 or 48. I have changed so many things in that plan, and I've just reorganized it so much that I really couldn't give you a red line document, and because it looks very different. It looks very different, and there are 9 things that are different from it. A lot of content from the old plan is in the new plan, but it looks very different, and these are the 9 reasons why they are different. Number 1, the QAPI plan is not a plan just for JPS. A QAPI plan is something that every surveyor looks at, so you have to write it from a perspective from both internally and externally. It should explain what JPS is without knowing what JPS is. So it is written from both perspectives, and that's where you'll start to see a little bit difference. That's 1. Number 2, I've taken it from a 14-page document to a 17-page document. It would be inhuman to not have a table of contents. So there's a table of contents to actually articulate where the plan is, what do you need to do, so you can go into the plan. The second one, going back to that external perspective, the introduction actually now provides a really good overview of what JPS is. What do we do? What services do we provide? If I'm not in JPS, can I read it and get through it? It gives context to what the plan is. It puts it in perspective if you're a surveyor who's never worked at JPS to read it and say, I understand JPS. So that's the third one. The fourth one is the purpose, objectives, and the rationale for the plan. Well, it was very good in the old plan. It just needed to be improved. It needed to actually improve that perspective that I was just talking about. And more importantly, how it connects with JPS strategic priorities. That was the missing piece. How does it really connect to what we are trying to do from a strategic standpoint? The fourth one that's actually materially new is something that's happened in the last 5 to 8 years in healthcare, is to think about healthcare quality as a systems of improvement. How do you think about a management system and not discrete projects of quality improvement or quality assurance? So it brings in this concept of quality management system that started about 8-9 years ago, and kind of creates a systemic way of thinking about articulating the organization's leadership and accountability and governance structures to help the QAPI plan be successful. That is the circle. How do you bring a system of thinking that has quality at its core, organizes leadership, governance, accountability, and then connects it back to how that will connect back to the QAPI plan being successful? So and under that section of the quality management system, we looked at every committee and council. And what we found is we have a council that's called the Quality Council. And when I looked at the work it does, it's much more than that. It's a network quality and patient safety council. So we thought maybe just call it that instead of giving it a name that doesn't make inherent, it doesn't really reflect the work. So it's change in nomenclature. Number 6 actually is it's very easy for us who work in the system to know which quality council, which committee goes where, how does it connect to the board. But when you are outside the system and looking at it, a visual helps. A visual really helps connect the dots and seeing, I'm reading this, this is how it flows. So some of the questions our surveyors come and says, does this work actually connect all the way to the senior most leadership? How does it connect to the board? Not having a visual kind of puts you at a disadvantage. So what we did is it actually created the visual. So the visual actually provides you how these committees are structured, what goes there. It's not a visual that says everything that comes to the committee, but significant committees and councils that report. The other missing piece in the previous QAPI plan was how does this committee, the quality committee of the Board of Managers, connect with the quality work? We know that the MEC presents to the Board of Managers, but how does this committee get input? And as I've seen the last 8 months of work, we are actually giving you work from the Quality Council. Most of the work that happens in the Quality Committee actually comes up to you in this framework. I just redesign it to get it to you. So this visual brings that nuance to that work. The seventh one is we kind of merged patient safety and performance improvement in the previous copy into one section. They're kind of together, performance improvement and patient safety. It's the subsections of what we try to do is pull it apart. We created a section for patient safety, put stuff in patient safety where patient safety should be. We put sections in performance improvement where performance improvement should be there. In that section of performance improvement, we actually added clarification on what improvement methodologies we will do. So there is a list of quality improvement methodologies that we list out, FEMA, PDSA, there are other things that are there. So we call them out, we call them what it is. So these are the tools that we as an organization will use. So when we get asked, what tools do you use? We can say based on the copy plan, these are the things we use. And then lastly, it is always good to give an external viewer an example of what our network process maps look like. So if you are, it's good to give them an example to say, how does a process from a patient perspective? How does it flow from a patient support perspective? How does it flow from an administrative perspective? And what does the hospital support processes look like? So there is a visual that kind of does a swim lane graph of these 4 perspectives and network processes that go through that. So again, I have to apologize. I should have just given you a red line document, but there was I had to rearrange them to make sure that actually aligns with the work we are trying to do. So those are the thematic changes. Please ask me questions because we did a lot of work into this and I need an additional perspective to see if there's something missing, something can be made better. While others think nothing has changed in terms of the board's role, the role of the MEC, the role of the committees that report to the MEC, none of that has been materially altered. It just has been reorganized to capture the flavor of quality improvement from an internal and external perspective in a more cohesive way.
I thought that was a good, clear way to look at it so you could see all of the things that is happening and which operation is managing that. Mm-hmm. So I like that, okay?
Thank you.
I had the old plan, so I thought it was a good outline of how everything followed and you could look and follow and know exactly what we should and should not be doing.
How many old plans do you have? 40. She has about 40.
I probably have. Well, a few. I'm going through and sending some of the old stuff back, but it's a good way to look at it, and so you clearly see what we should be doing and how much we have to cover and all the little pieces. And I think sometimes for non-healthcare folks, this process map make it simpler to me. Now that might be because I'm healthcare, but I do think it helps the non-healthcare folks see how it all fits together. So I was impressed with, there are no definitions that you didn't define, so that was a good thing.
Okay, it looks like a good summary of everything we talk about in here. And the only thing that I kind of question is the diagram of the quality structure and functions, because it kind of puts like, the JPS network quality and safety control can either go through this way or that way. I know there's like a dotted line. I'm not quite sure the difference between the dotted line.
So I
guess I just didn't want to de-emphasize that it needs to go through the process through the medical committee. You can't just bypass and go through this committee to get to the board of managers.
So we, by the bylaws, are required to have a solid line. The Infection Prevention Patient Safety Council and the new Network Quality and Safety Council by bylaws are required to have a solid line to go through PSQG, through MEC and the Board of Managers. This dotted line just shares the work that's happening, where most of the work that I've been doing in the last 3 months, three times that I've come to this, it just strikes that this is work that's coming up to this committee so that everything is captured and closes the loop.
So I will say, the organized medical staff had exactly the same question that you did. So thank you for seeing it in the same sort of way. This went through the Medical Staff Bylaws Committee and went to MEC and had robust discussion at many levels. And Dr. Carla Pudi was very collaborative in trying to get to this final document because we had a lot of feedback for him. So thank you for receiving all of our feedback. The way we're interpreting the dotted line is it's really reporting. So the Network Quality and Safety Council has a dotted line reporting relationship to this committee so that this committee can be made aware of all the activity that's going on, which is what you've been hearing anyway, as long as I've been sitting on the committee.
Right.
But the fact that it's a solid line through MEC, we believe preserves the CMS requirements that the quality is delegated to the medical staff from the Board of Managers. So that's sort of how we explained it, if that helps you think about it at all.
It meets that requirement by calling it out and also functionally gives more clarity on the work that's coming up here. So it kind of makes it a really tight circle of information.
This is so nuanced, and so there's probably nothing wrong with the way it's drawn out here. I guess my question is the dotted line, should it really be more from the MEC to us at this committee rather than from the Quality and Safety Council? Like, do we let anything come to this committee that hasn't been through the MEC? That's kind of a question for Dr. Miles, I think.
That's a really good question. Should there be any information reported here that we have not heard about? I mean, probably not, because the medical staff has authority over all of quality functions.
And then I think, the way I see this is it should go to the MEC first, then through us, then to the Board of Managers. Truly, I don't know if anything goes directly from the MEC to the Board of Managers without it coming through this committee.
Yeah, also a great question. The only thing I'm aware of that goes, the things that go directly from the MEC to the Board of Managers and don't come through the Quality Committee, of course, is the privileges. And that goes straight to MEC. Also, our policies relative to medical staff activity. So, for example, a credentialing policy would go straight from the MEC to the Board of Managers and not come through here. So I think that's part of what made it slightly difficult to put a diagram, because, this goes, but that doesn't.
And outside of policy,
Right.
policy.
Yep.
So there's still.
There's still some other.
Yeah. So, I don't think it needs to be changed. I just think that we just need to clarify that you can't circumvent the procedures by just coming straight to us.
But I kind of saw that everything had to go through JPS, Network Quality and Safety Council.
Correct.
That's where they are doing that, and that's where all of this, MEC and all of that's connected. And the only thing I'm noticing is that from that committee, it comes here.
There's a lot of information from the Net Quality Council that I bring up here. A lot of information that comes up here. All the regulatory work, all the surveys, all the quality work happens there.
Well, maybe let's ask it this way. Is there anything that goes to the Network Quality and Safety Council that would not be presented to PSQG? Or does PSQG hear everything that we hear?
Yeah. PSQG hears everything that you hear. Yeah.
Do claims quality go through here?
That's what I'm thinking. I think that the come from either PSQG to us or MEC to us, so that you can clearly see that everything that's quality and safety needs to go through that pattern, but some of it gets to us too. I don't know.
I'll defer to Daphne.
Yeah, I think that sounds right, because it sounds like what you're saying, because the way it's drawn out, anything that went to that JPS Health Network Quality and Safety Council would go to PSQG, MEC, or both before it came to quality. So really, the dotted line can be drawn at that higher level. I don't think you kind of got this closed circuit here, so for purposes of this approval, I don't think it impacts, but we could probably clarify that.
So just another line from PSQG, which means PSQG will formally report out here.
I mean, I
Well,
think
you
that's-
are the co-chair of PSQG.
Yeah,
Yeah.
I think that's kind of
I
what
mean,
you're,
it does
I think
work
that's,
because
what
the
I'm
CMO
hearing is
is the
that that's
co-chair
what
of
you're kind of
PSQG.
doing now.
Okay, so
You're
just have the
taking the
PSQG go there.
information from them
Okay.
and reporting it out here.
So we can add another line from PSQG that connects to the board of this committee.
I think drop the Network
Yeah.
Quality and Safety Council dotted line and move it over to
Yeah,
PSQG.
that's all you're doing, is
Fine.
moving
And then
it.
that way you represent PSQG to this committee.
That's fine.
And right. And then PSQG still reports to MEC.
Okay. Again, that's an easy change. We just have to change the language and change. That's easy to do.
Yeah.
Yeah.
And while you're doing that, on page 51, I believe this was probably written before we had our results from our engagement survey, but you can update that because at the top you say that these are results from October 1st through September 30th of 2023. And we
Yes, ma'am.
did have our results, which was 4.21.
I will change that.
And
Do we-
and eliminate that last sentence there. Otherwise, it gets confusing.
Yeah.
The next annual, I can take
Update
that
this
out.
every year, the plan?
This has to be updated every year.
Okay.
Yeah.
So Dr. Duncan changed the 4.08 to 4.21
Take that last sentence as.
and take the last sentence out.
Yeah.
Because you,
Thank you.
on the top there, you said that you're resulting out between October 22 through September 2023.
Okay. Got it. Thank you for that. It always requires more revisions than I thought. This is version 52. We'll get there. Important to get
We could
feedback.
redline this one for you.
No, thank you. Thank you.
Do we have to like
I don't-
send this back to MEC
I
with these?
don't think so
changes?
because
Those are substantive changes.
Yeah.
I think we would be, I don't think that needs to go back.
Okay. I don't want to skip the steps in my diagram.
We have Janet and Dr. Carla Pudi here. And they say we can-
I think your points are well made, Dr. Holland.
changes, I
I
don't
think
think
that was on point and consistent with what the medical staff's intentions were for the QAPI plan.
Can I make one other comment? And I'm going to ask your apologies in advance. I'm going to bring this back to you to add another section sometime in February. We are required by CMS to have a healthcare equity plan which needs to connect with the quality plan, and that needs to be part of the institutional strategy. That's a document that we are working through right now. It is, we are supposed to go live by January, February 2024. So that's a document that we will bring to you. My plan was to add another line, table of contents, and put that plan into this. So in case you see this, me bring this back to you in February, it's not because of me, because of CMS. We need to make sure that this connects back to the plan and integrates with the infrastructure that we have built here. So that's for future, but I wanted to give you context now.
Okay.
Okay.
Well, I will make a motion to approve the QAPI plan for is this the 2024 or 2023? 2024 QAPI plan with the changes that we have stated.
I'll second.
All right, have approved.
Thank you.
I think that takes us to the end of our agenda. Anything else anybody wants to add? Okay. So we will adjourn. And when's our next date? Lonnie, do you know when we're meeting again? February? For the next installment of the QAPI plan.
Yes, just in time.
All right, thank y'all, everyone.
Thank you.